Welcome back to the Deep Dive. Today, we're tackling a really big one, hypertension. You often hear it called the silent killer, and, well, that's pretty accurate.
It really is. Silent because the symptoms often don't show up until serious damage is done. And killer because, well, the damage it causes is widespread and relentless.
So our mission today, for you listening, is to get beyond just thinking of blood pressure as two numbers on a cuff reading.
Exactly. We want you to understand the physics behind those numbers, the hemodynamics, and what that pressure is actually doing to the body over time, the pathology.
Okay, let's start right at the beginning. Definitions. What's the official threshold based on the current guidelines where you say, okay, this is hypertension?
Right. So based on the ACAA 2017 criteria, we define hypertension, or HTN, as a persistent elevation of blood pressure. The key numbers are 130 millimeters of mercury systolic over 80 diastolic. So 130 over 80 or higher, consistently.
Consistently. That's the important part. Once you're there, the pressure is already starting to cause some level of microscopic wear and tear.
That's right. Now, when we talk about causes, there's a major split.
Yeah, the vast majority of cases get this label, essential hypertension. I always found that term a bit strange. What does essential really mean here?
It's a bit of a historical term, maybe not the clearest. It essentially means we haven't pinned it down to one single identifiable cause. This covers about 90 to 95% of all hypertension cases.
So it's like a mix of factors.
Exactly. It's what we call multifactorial. There's a strong genetic component. It's polygenic, plus environmental factors like diet, stress, lack of exercise, the usual suspects.
And the other slice, the smaller group.
That's secondary hypertension, only about 5 to 10% of cases. But crucially here, there is a specific, identifiable, and often treatable underlying cause. Could be kidney disease, an endocrine issue like a hormone-secreting tumor, or maybe a vascular problem.
You mentioned essential HTN being polygenic. The sources we looked at to dive deep into things like polymorphisms in the renin-angiotensin-aldosterone system, RAAS, or specific genes for kidney sodium channels like NSE. That sounds complex. For someone listening, what's the functional takeaway?
Yeah, those gene names can sound intimidating,
Ah.
but think of them functionally as tiny volume control knobs inside your kidneys and blood vessels. These genes basically dictate how efficiently your body handles salt and water and how tightly your blood vessels constrict.
So variations mean different settings on those knobs.
Precisely. If you have certain polymorphisms, maybe an ENA or another one called alpha-adducin, your body might just hang on to sodium more readily than someone else's. A normal amount of salt in your diet could push your pressure up significantly. You're essentially more salt sensitive because your genetic thermostat for blood pressure is set a bit higher.
That's a great way to visualize it. Okay, let's shift gears to the actual pressure numbers in section 1, SPP and DVP, systolic and diastolic. What's physically happening in the body for each of those?
Okay, SPP, systolic blood pressure. That's the peak pressure in your arteries. It happens right when your heart's main pumping chamber, the left ventricle, contracts that systole and ejects blood out into the aorta.
And what determines how high that peak goes?
Primarily two things. How much blood the heart pumps out with each beat, that's stroke volume, which contributes to cardiac output. And second, how stretchy or compliant your big arteries, especially the aorta, are.
Got it. And the bottom number? DBP.
DBP, diastolic blood pressure. That's the lowest point the pressure drops to in your arteries. This occurs when the heart muscle relaxes and fills with blood during diastole.
And what mainly dictates that lower number?
This one is mostly determined by the resistance in your smaller blood vessels, the arterioles. We call this total peripheral resistance, or TPR. If those little vessels are clamped down, constricted, your diastolic pressure will be higher.
So we have the peak pressure when the heart squeezes and the minimum pressure when it relaxes. But organs need continuous blood flow. How do we figure out the average pressure that's actually driving blood through tissues? That's the mean arterial pressure, right? The MAP.
Exactly. The MAP is really the key pressure for organ perfusion. And there's a formula we use to estimate it. MAP equals the diastolic blood pressure plus 1/3 of the difference between the systolic and diastolic pressures. So MAP equals DBP plus an SPP.
What always struck me as interesting there is the math. Even if the systolic number is way higher, the MAP calculation gives more weight to the diastolic pressure. Why is that?
It's because of timing. The cardiac cycle isn't split 50-50 between contraction and relaxation. Your heart actually spends more time relaxing and filling in diastole. Roughly 2/3 of the cycle is diastole.
Ah, okay. So the pressure during that longer phase has a bigger impact on the average.
Precisely. And during that diastolic phase, it's the elastic recoil of your large arteries, like the aorta, that keeps the blood moving forward smoothly, even though the heart pump itself is momentarily off or relaxing.
That elastic recoil, that sounds like the classic water tower analogy.
It's a perfect analogy. Think of the heart's contraction, the systole, as the pump actively pushing water up into the tower that's your SBP spike. But the continuous flow coming out of the taps, even when the pump isn't running, that's maintained by the pressure from the stored water in the tower acting under gravity.
And in the body.
In the body, the elastic stretch and recoil of the aorta and large arteries during diastole acts like that stored water pressure. It smooths out the flow and maintains the MAP, ensuring your organs get blood constantly.
But what happens when that essential elasticity starts to fade? We see this particularly in older individuals, right?
We do. And it leads to a specific pattern called isolated systolic hypertension, or ISH. This is really common as we age. The arteries lose their compliance, they get stiff, think less like a flexible garden hose and more like a rigid pipe.
So the heart pumps into a stiff pipe.
And the systolic pressure spikes really high because the stiff artery can't expand to absorb that sudden volume of blood. But because the artery has lost its elastic recoil, it doesn't snap back as effectively during diastole.
So the diastolic pressure.
The DBP often stays normal, or might even drop a little. The key clinical sign here is a widened pulse pressure that's the difference between SBP and DBP. It's a hallmark of arterial stiffening.
Okay, moving on. The stakes really escalate when blood pressure surges into what's called a hypertensive crisis. This isn't just high BP, this is danger zone territory.
Absolutely. We're talking about very high numbers, typically defined as 1800, 120 millihg or higher. But crucially, the number itself isn't the only thing that defines the immediate risk.
Right. There's a critical distinction within that crisis level, isn't there? Between urgency and emergency.
Yes. Both involve pressures at or above 180 or 120. A hypertensive urgency means the pressure is that high, but there's no evidence of acute, ongoing damage to major organs. It's serious, needs attention, but can usually be managed more gradually, often outpatient.
Okay, so what tips it over into a full-blown hypertensive emergency?
That's when you have those same severely elevated pressures, plus clear evidence of acute, new, or worsening damage to critical target organs: brain, heart, kidneys, eyes, major blood vessels.
This requires immediate action, right? Usually in an ICU setting, controlled BP reduction.
Definitely. The pressure is so high that the body's normal self-regulation of blood flow, autoregulation, is overwhelmed, and small vessels start to leak or even rupture. It's a true medical emergency.
Our sources had a great mnemonic for remembering those key target organs and the kind of damage we look for. BEKAR. Let's walk through that.
Okay. B is for brain. Acute damage here could be hypertensive encephalopathy, severe headache, confusion, seizures, or it could be an acute stroke, either ischemic or hemorrhagic. Very serious. E is for eye, specifically the retina. We look for signs of hypertensive retinopathy like flame hemorrhages, cotton wool spots, which are nerve fiber infarcts, and the really alarming sign of severe acute pressure, papilledema, which is swelling of the optic disc. K is for kidney, acute kidney injury. The filtering units get damaged, leading to rising creatinine, maybe blood or protein in the urine. We call the severe form malignant nephrosclerosis.
Hey.
A is for aorta. The immense pressure and shear stress can literally tear the inner lining of the aorta. That's an aortic dissection. Classic symptom is sudden, severe, tearing chest or back pain, and often you'll find a significant difference in blood pressure between the two arms, a surgical emergency.
And finally, R. This one's a bit different.
R is for red blood cells, or RBCs. In these extreme pressures, the small arterioles get so damaged and narrowed that red blood cells actually get sheared apart as they try to squeeze through. This causes a type of anemia called microangiopathic hemolytic anemia, or MAHA.
And you can see that damage under the microscope.
Yes, you see fragmented red blood cells called schistocytes on the peripheral blood smear. It's a direct sign of microvascular damage from the severe hypertension.
Wow. BEKAR, brain, eye, kidney, aorta, RBCs. That really paints a picture of the immediate dangers. Now let's shift focus slightly in section 3 to the chronic damage. What does years of elevated pressure do to the blood vessels themselves at a microscopic level?
Well, with chronic, long-standing hypertension, the body tries to protect the vessel walls. One common finding, especially in smaller arteries and arterioles, is hyaline arteriolosclerosis.
Hyaline, Like glassy.
Exactly. The vessel wall thickens with this homogeneous pink glassy material. Its leaked plasma proteins and excess basement membrane matrix. It narrows the lumen, the opening of the vessel, which contributes to chronic ischemia in the organs supplied, like the kidneys. It's often called benign nephrosclerosis, though it's not truly benign over decades.
Okay, that's the chronic, slow burn. What about when the pressure is severely high, maybe oscillating, or in that crisis range we just discussed?
Then you see more aggressive acute changes. One is fibrinoid necrosis. Here, the vessel wall itself is injured so badly that plasma proteins, including fibrin, leak right into the wall, causing necrosis, cell death. It looks bright pink and smudgy under the microscope.
And there's another one often seen with it.
Yes, often alongside fibrinoid necrosis and severe or malignant hypertension, you see hyperplastic arteriolosclerosis. The smooth muscle cells in the vessel wall rapidly proliferate, arranging themselves in concentric layers.
The classic description is.
Onion skinning. It looks like the layers of an onion. This also dramatically narrows the lumen and is a hallmark of severe acute hypertensive damage.
Okay, so the vessels take a beating. Let's bring it back to the pump itself, the heart. Specifically the left ventricle, which is doing all the work pushing against that high pressure systemically. How does it adapt?
It adapts the way any muscle does when it faces increased resistance. It gets bigger and stronger, but in a specific way. The left ventricle experiences increased afterload, the pressure it has to overcome to eject blood.
So it bulks up.
Yes, it adds new contractile units, sarcomeres, in parallel. This causes the muscular wall of the ventricle to thicken, often dramatically, without the actual chamber size increasing much initially. This is concentric left ventricular hypertrophy, or LVH.
The heart becomes like a bodybuilder's muscle, thick and powerful. But there's a major downside to that kind of hypertrophy, isn't there?
There absolutely is. That thick muscular wall becomes very stiff. It loses its compliance, its ability to relax and stretch properly during diastole to fill with blood.
Even if it can still pump hard.
Yes, the squeezing function, the ejection fraction might still be normal, especially early on. But the filling is impaired because the ventricle is too stiff. This is the fundamental problem in diastolic dysfunction.
And that's the mechanism behind a specific type of heart failure.
Precisely. It's the main cause of heart failure with preserved ejection fraction, or HFpEF. The pump works okay, but the heart can't fill properly, leading to backup of pressure and symptoms of heart failure.
Is there a classic sound you might hear on a physical exam that points towards this stiff ventricle?
Yes, the high-yield physical finding is the S4 gallop. This is an extra heart sound that occurs late in diastole. It's the sound of the atrium contracting forcefully, trying to push that last bit of blood into a stiff, non-compliant ventricle just before it starts to contract. Lub-dub. Boom. That boom is the S4.
And one more critical issue with that thickened heart wall.
Yeah.
It creates its own supply-demand problem, right?
Exactly. The thickened muscle mass has a significantly increased demand for oxygen and nutrients. But the network of tiny blood vessels within the heart muscle, the capillaries, doesn't necessarily grow proportionally with the muscle bulk.
So a mismatch.
A major mismatch. This leads to a state of relative subendocardial ischemia, meaning the innermost layer of the heart muscle, the subendocardium, is chronically undersupplied with blood, especially during times of increased demand.
And the consequences of that ischemia.
It can lead to cell death, scarring, or fibrosis within the heart muscle. And importantly, this fibrosis disrupts the normal electrical pathways in the heart, making it much more prone to developing dangerous arrhythmias.
Like which one in particular?
Atrial fibrillation, or AFib, is very commonly associated with hypertensive heart disease and LVH. That fibrosis provides the substrate for chaotic electrical activity.
Okay, let's shift gears for our final section. Back to that 5 to 10%, the secondary hypertensions. You said these are potentially curable if identified. So spotting the clues is really high yield for clinicians and interesting for anyone learning this stuff. What are some classic clinical pictures or vignettes that should make someone think, maybe this isn't just essential HTN?
Absolutely. Finding these is key. One classic clue involves electrolytes. If you have a patient with hypertension, especially if it's resistant to treatment, and they have low potassium, hypokalemia, you have to think about primary hyperaldosteronism.
Also known as Conn syndrome.
That's right. An adrenal tumor, or sometimes just overactive adrenal glands, turns out too much aldosterone. Aldosterone tells the kidneys to hold on to sodium and water, causing volume expansion and hypertension. But it also makes the kidneys waste potassium.
So HTN plus low potassium. Anything else?
Often they'll have a metabolic alkalosis too, because of how aldosterone affects acid-base balance. And critically, because the high BP is volume-driven, the body tries to shut down the normal trigger for aldosterone, which is renin. So you'll typically find low plasma renin activity. That combination HTN, hypokalemia, metabolic alkalosis, and suppressed renin strongly suggests cons.
Okay, what's another classic secondary cause vignette? Maybe something more episodic.
Ah, yes. If a patient describes spells or paroxysms of symptoms that come on suddenly, that's a big red flag for pheochromocytoma.
The catecholamine tumor.
Right. Usually in the adrenal medulla, it releases bursts of adrenaline and noradrenaline, so the
Yeah.
patient doesn't just have high BP all the time, they have these sudden attacks. The classic triad of symptoms during an attack is severe headache, profuse sweating, diaphoresis, and heart palpitations or racing heart. And during these spells, their blood pressure can shoot up to extremely high levels.
It's like the body's fight or flight system is getting jammed on overdrive sporadically.
Exactly. The sympathetic accelerator is stuck. Finding and removing the tumor can cure the hypertension.
Okay, how about a clue you might pick up just from a careful physical exam, maybe comparing different parts of the body?
Good one. If you find significantly higher blood pressure in the arms compared to the legs, or if you feel that the pulses in the feet or groin, the femoral pulses, are noticeably weaker or delayed compared to the pulse in the arm, the brachial pulse, you should strongly suspect coarctation of the aorta.
A narrowing of the main artery.
Yes, a congenital narrowing, usually just after the arteries branch off to the arms. This obstructs blood flow to the lower body, causing low pressure downstream, but high pressure upstream in the arms and head.
And sometimes there are visible signs on imaging.
Yes, especially in younger patients or children who've had it for a while, you might see rib notching on a chest x-ray. The body develops collateral arteries to bypass the blockage, and these enlarged arteries can erode the underside of the ribs over time. Finding that brachial femoral pulse delay or pressure difference is key.
Okay, one more common secondary cause, especially relevant for resistant hypertension and often linked to lifestyle factors like obesity.
You're likely thinking of obstructive sleep apnea or OSA.
Yes. How does that cause high blood pressure?
The sources we reviewed highlight this connection strongly. During sleep, people with OSA have repeated episodes where their airway closes, they stop breathing briefly, and their oxygen levels drop. That's intermittent hypoxia. This triggers a cascade of responses.
Like what?
It causes chronic activation of the sympathetic nervous system, that fight-or-flight response again, and it also constantly activates the RAS system we talked about earlier. This combination leads to sustained hypertension that's often very difficult to control with standard medications.
So someone's on 3 or more BP meds, including a diuretic, and their pressure is still high.
You absolutely need to screen them for OSA. Identifying and treating the sleep apnea, often with a CPAP machine, can sometimes dramatically improve their blood pressure control. It's a huge, often missed contributor to resistant hypertension.
That brings us towards the end of this deep dive. We've really covered a lot of ground. We started with the hemodynamics, understanding SBP, DVP, and how MAP is weighted towards the diastolic phase due to that elastic recoil.
Then we looked at the immediate dangers of hypertensive crisis, using the BEKAR mnemonic brain, eye, kidney, aorta, red blood cells to remember the types of acute target organ damage.
We explored the chronic scars left by hypertension, the hyaline and hyperplastic arteriosclerosis in vessels, and the concentric LVH leading to that stiff heart, diastolic dysfunction, HFpEF, the S4 sound, and increased risk of ischemia and arrhythmias like AFib.
And finally, we touched on those crucial secondary causes, Conn syndrome with hypokalemia, the episodic spells of pheochromocytoma, the pulse differences in coarctation, and the often overlooked role of obstructive sleep apnea in resistant HTN.
It underscores that managing hypertension isn't one size fits all.
Not at all. Optimal management means thinking about the underlying pathophysiology in that specific patient. For someone post-heart attack, a beta blocker and ACE inhibitor are crucial. For an older patient with stiff arteries causing isolated systolic hypertension, a calcium channel blocker or a thiazide diuretic might be more effective targeting that specific issue. You treat the patient and their physiology.
So to wrap up, here's a final provocative thought for you, our listener, to consider. We talked early on about how essential hypertension is polygenic, involving those genetic volume knobs like ENSE and alpha-leucin that influence salt sensitivity and vascular tone.
Where are you going with this?
Well, if you get better and better at mapping an individual's specific genetic profile, understanding precisely how their kidneys handle sodium, how their blood vessels respond to stress signals, how might future precision medicine use that information? Could we potentially tailor a lifelong preventative strategy diet, lifestyle, maybe even preemptive microdosing of certain meds based on your unique genetic risk, long before your blood pressure even begins to approach stage 1? Something to think about.